Most people follow the same path with varicose veins. Spider veins appear and get ignored. They become more visible, so a cream gets purchased. Eventually, the veins start bulging. A specialist gets involved, and surgery follows. Then, roughly 2 years later, the veins come back. That recurrence isn't bad luck. It's the predictable result of treating only what's visible while leaving the underlying cause untouched. The common assumption is that varicose veins are a cosmetic or skin-level issue. In reality, they're not primarily even a vein problem. They're a mechanical failure in how blood moves through the legs, and that failure has specific, identifiable causes that can actually be addressed. To understand why, it helps to know what a varicose vein actually is. Inside every vein are tiny one-way valves, small flaps of tissue that let blood flow upward toward the heart and then snap shut to stop it from sliding back down. When a valve weakens, blood pools behind it, pressure builds inside the vessel, and the wall bulges outward. That twisted, visible vein under the skin is simply a valve that has stopped doing its job. Consider the physical challenge the leg veins face every day. The heart pumps blood downward through the arteries easily with gravity's help. But getting blood back up from the feet to the heart is a climb of roughly 4 to 4.5 feet in an average adult. And the heart plays no direct role in that return trip. That job belongs to two systems, the valves and the leg muscles. Every time the calf muscle contracts, it squeezes the vein like a pump and pushes blood upward. The valve closes behind it so the blood can't fall back. When the muscle relaxes, the vein refills from below, and the next contraction sends the blood higher still. That's the mechanism that gets blood back to the heart. If either piece of this system breaks down, the valves or the muscle pump, blood stagnates. Pressure builds, and the vein walls stretch in response. This is the core mechanical story behind varicose veins, and it's the reason cosmetic treatments alone tend not to hold. They address the stretched, visible vein without touching the pressure and pump failure that caused it in the first place. Understanding this system is the starting point for actually doing something about varicose veins rather than just managing their appearance. The next question is what actually causes the valves to fail in the first place. And there turn out to be 3 separate mechanisms behind it, each with its own root cause and its own fix. One of them, a source of pressure from organs sitting above the leg veins, is rarely discussed, even though it plays a significant role in why blood struggles to make the climb back to the heart. The remaining parts of this rewrite walk through those 3 causes, then move into a 5-step plan for addressing them. Improving how easily blood flows, reducing the swelling that compresses veins from outside, reactivating the leg's muscle pump, clearing mechanical blockages along the vein's pathway back to the heart, and finally strengthening the vein wall itself with the right nutrients. Each step targets a distinct part of the underlying mechanical failure, and together they're meant to work as a system rather than a series of isolated fixes. If valves and muscles are what keep blood moving upward through the legs, the next question is what actually causes those valves to break down. There are 3 main mechanisms, and the first one rarely gets discussed. 'Cause 1, pressure from above, the organs of the lower abdomen. The intestines, the uterus, the bladder sit directly above the major veins that drain the legs. When those organs become heavy, displaced, or prolapse downward, they press on the large pelvic veins beneath them. That pressure creates a partial blockage, so blood trying to climb out of the legs meets resistance at the top and backs up. The result is elevated pressure throughout the entire leg vein system. Pregnancy contributes to this. So does chronic straining on the toilet and repeatedly lifting heavy loads. Essentially, anything that pushes the abdominal organs downward adds to a burden the leg veins are already carrying. 'Cause 2, a structurally weak vein wall. Vein walls are built from collagen and elastin, the same fibers that give skin its elasticity. In some people, these fibers are simply thinner than average from birth, a pattern known as connective tissue dysplasia, an inherited tendency toward more fragile connective tissue generally. People with this pattern often also notice unusually flexible joints, a history of easy sprains, and varicose veins that showed up early and spread quickly. Beyond genetics, several factors weaken the vein wall further. Vitamin D deficiency is one, since vitamin D is essential for collagen production. A shortage of bioflavonoids, plant compounds that reinforce vessel walls and reduce their leakiness, is another. And chronic low-grade inflammation in the surrounding tissue, often driven by diet, slowly erodes the wall's structural integrity over time. Cause 3. Thick blood. Blood viscosity. How thick or thin blood is directly affects how hard the veins have to work to move it. Thicker blood moves more slowly, builds more pressure, and puts more stress on the vessel walls. In otherwise healthy people, the single biggest driver of blood viscosity is dehydration. Not severe dehydration, but the chronic, mild underhydration that most people carry around every day without realizing it. These 3 mechanisms, pelvic pressure, structurally weak vein walls, and thick blood, rarely act alone. In most people with progressing varicose veins, some combination of all 3 is at work simultaneously, which is part of why a single intervention, like a cream or even a surgical procedure, tends not to hold on its own. Addressing the visible vein without addressing the pressure pushing on the pelvic veins, the nutrient deficiencies weakening the wall, or the chronic dehydration thickening the blood, leaves the underlying system exactly as vulnerable as before. This is also why the fix has to be systemic rather than local. A 5-step plan built around these 3 causes follows in the next parts. First, restoring blood fluidity to ease the viscosity problem, then reducing tissue swelling that compresses veins from the outside, then reactivating the leg's muscle pump to restore circulation, then clearing mechanical obstructions along the vein's path back to the heart, and finally reinforcing the vein wall itself with targeted nutrients. Each step maps directly back to one or more of the 3 causes described here, which is the reason the plan is meant to be followed as a whole rather than picked apart into isolated habits. Step 1. Improve blood fluidity. The medical term is hemorrhagiology, the study of how blood flows. Better hemorrhagiology means lower pressure on the vessel walls and a lower risk of clot formation. The starting point is water. For someone dealing with varicose veins, a reasonable minimum is about 30 milliliters of water per kilogram of body weight per day. Someone weighing around 150 pounds, roughly 68 kilograms, would aim for about 2 liters. Someone at 175 pounds would be closer to 2.5 liters. This means actual water, not coffee, tea, juice, or soup. Caffeinated drinks are diuretics, so they cause the kidneys to excrete more fluid than was consumed, meaning the body can end up with less net water despite the drink going in. That doesn't require giving up coffee. It just means treating each cup as a cue to add an extra glass of water elsewhere in the day. 2 natural additions are worth layering on top of hydration, since both improve blood flow and act as venotonics, compounds that help vein walls contract and hold their shape. The first is turmeric. Its active compound, curcumin, reduces inflammation in the vessel wall, makes platelets less likely to clump together, and improves circulation in the smallest blood vessels. Effects with real pharmacological backing rather than folk remedy status. About half a teaspoon added to a warm meal each day is a meaningful therapeutic amount. The second is ginger, whose active compounds, gingerols and shogols, reduce blood viscosity, improve microcirculation, and have a direct anti-inflammatory effect on vessel walls. A practical way to use it. Steep sliced fresh ginger in boiling water, add a wedge of lemon, pour it into a thermos, and sip it steadily throughout the day rather than all at once. That keeps the concentration of active compounds stable in the blood instead of spiking and crashing. Step 2. Reduce tissue swelling in the legs. This is less obvious than hydration, but it matters just as much. When the tissue surrounding a vein is waterlogged and puffy, it compresses the vein from the outside, making it harder for blood to move through, which worsens the swelling further, which compresses the vein more. It's a self-reinforcing loop. Tissue swelling is largely driven by food, and 3 categories stand out. The first is sugar. The body stores excess sugar as glycogen, and each gram of glycogen holds roughly 3 grams of water. So higher sugar intake directly means more water retained in the tissues, on top of the inflammation sugar triggers in vessel walls. Hidden sources are worth watching for. Packaged fruit juices, flavored yogurt, bottled sauces, and mass-produced bread can carry as much sugar as a soda. The second is MSG and similar flavor enhancers, which disrupt the sodium-water balance at the cellular level, causing cells to retain more sodium. And sodium pulls water with it. These show up heavily in chips, crackers, fast food, frozen meals, and packaged soups. The third is dairy. For many people, Casein, the primary protein in cow's milk, triggers low-grade gut inflammation that contributes to fluid retention throughout the body. This doesn't apply to everyone, but if leg swelling is a persistent issue, a 3 to 4 week dairy elimination is worth trying to see whether it makes a difference. On the other side, certain foods support the kidneys in clearing excess fluid. Cranberries and lingonberries blended with water. No added sugar act as natural diuretics, as do herbal options like horsetail, corn silk, parsley, and celery. In-season produce like cucumber, watermelon, and cantaloupe. 80 to 90% water by weight. Carry a mild diuretic effect as well. None of this requires anything complicated or expensive. Consistency is what makes it work. Of all 5 steps, this may be the most important, and the one most often skipped. As covered earlier, the leg muscles are the engine driving venous return. Every calf contraction is effectively a pump stroke. If that pump doesn't fire, blood doesn't move. This is exactly why varicose veins show up so often in people who stand or sit in one position for hours at a time. Surgeons, hairstylists, retail workers, desk workers. 8 to 10 hours with the legs largely stationary means 8 to 10 hours with the venous pump essentially switched off. Blood sits, pressure accumulates, and vein walls stretch under the strain. There's a persistent myth worth addressing directly here. The idea that people with varicose veins should rest their legs and avoid exertion. That's not just inaccurate, it's counterproductive. Controlled physical activity isn't a risk for someone with varicose veins. It's part of the treatment. The activities actually worth limiting are heavy barbell lifts done with breath holding and prolonged hard running on pavement. Rhythmic leg movements that repeatedly contract and release the muscles, on the other hand, function as medicine for this specific problem. A simple 3 exercise sequence used in rehabilitation settings can activate the venous pump from the top of the leg down to the bottom. Exercise 1. Sumo squat, targeting the pelvic floor and inner thigh. Stand with feet wide apart and toes turned outward. Lower down as far as comfortably possible, then rise back up. 10 repetitions. The wide stance engages the inner thigh and glute muscles that govern venous drainage at the pelvic level, the top of the pathway leading back to the heart. Exercise 2. Standard squat, targeting the thighs. Feet shoulder width apart, toes forward, lower to roughly parallel, then stand back up. 10 repetitions. Breathing matters here. Inhale on the way down, exhale on the way up. Holding the breath during a squat sharply raises intra-abdominal pressure, which creates exactly the kind of downward force on the pelvic veins that makes varicose veins worse. Exercise 3. Calf raises, targeting the most powerful pump in the leg. Stand upright, rise slowly onto the toes, hold briefly at the top, then lower slowly. Continue until a mild burn appears in the calves. That sensation signals the muscle has been fully engaged and the pump has fired. The full sequence takes only 3 to 5 minutes and is worth doing at least 3 times a day. For anyone at a desk, standing up every hour to do at least the calf raises right at the workstation helps considerably. And taking the stairs instead of the elevator counts too. Walking in general is one of the most effective habits for vein health. 30 to 40 minutes of daily walking tends to produce measurable improvement in symptoms within 2 to 3 weeks. The underlying idea across all of this is simple. Movement isn't something to avoid because of varicose veins. It's one of the most direct tools available for treating them, because it's the only thing that reactivates the muscle half of the pump and valve system that moves blood back up the leg. Step 4 covers territory that rarely comes up in conversations about varicose veins, and it's often the reason vein problems keep progressing, even when someone is doing everything else right. Here's the anatomical path. Surface veins in the legs drain into deep veins, which travel upward through the back of the knee, become the femoral vein in the thigh, pass through the groin, and become the iliac veins in the pelvis. The 2 iliac veins merge into the inferior vena cava, the body's largest vein, which runs alongside the abdominal aorta, past the intestines, behind the liver, through a dedicated opening in the diaphragm, and finally into the right side of the heart. Along that long route, there are at least 5 points where external pressure can partially obstruct the vein. And if even one of those points is compressed, pressure builds in everything below it. No amount of exercise or hydration can override an upstream blockage like that. Point 1. The groin and pelvic region. The femoral vein passes through a narrow channel next to the cecum start of the large intestine on the right and the sigmoid colon on the left. Adhesions, chronic inflammation, or a bloated, gas-filled bowel in that area can compress the vein and impair drainage from the leg. Point 2. The small intestine. The loops of the small intestine fill most of the abdominal cavity. When the small bowel is distended, cramping, or sitting lower than normal, it presses on the iliac vessels, meaning chronic constipation, IBS, and persistent bloating aren't just digestive complaints, they're structural forces acting on leg circulation. Point 3. The liver. The inferior vena cava runs directly through liver tissue, so an enlarged, congested, or fatty liver can displace it and create resistance to flow, making fatty liver disease relevant to venous circulation, not just to metabolic health. Point 4. The diaphragm. The inferior vena cava passes through a dedicated opening in the diaphragm. A freely moving diaphragm actually assists venous return with each breath, creating a gentle suction effect that pulls blood upward. A chronically tightened diaphragm, from prolonged stress, poor posture, or sedentary habits, compresses that opening and impairs return flow. The approach to these obstructions is called visceral massage, manual mobilization of the abdominal organs done either by a trained practitioner or, with proper guidance, by the individual themselves. Gentle pressure over the cecum lower right and sigmoid colon lower left can help soften adhesions and ease tension around the vein. Slow, clockwise circular massage over the central abdomen supports intestinal motility and reduces pressure on the iliac vessels. Gentle sustained pressure just under the rib margin on a full exhale can help address diaphragm tension. These changes build slowly. Adhesions that took years to form won't resolve in a week, but consistent daily attention does make a difference. And once these mechanical obstacles start clearing, the rest of the plan becomes noticeably more effective. Step 5. Strengthen the vein wall itself. Alongside addressing mechanical factors, the vessel walls need the raw materials to stay resilient, which means correcting two common deficiencies. The first is vitamin D, essential for collagen synthesis. When it's low, vessel walls become less flexible and more prone to damage. Many adults in northern latitudes run chronically low, especially October through April, and a 25-OH vitamin D blood test targeting roughly 50. 100 nmol/L is worth discussing with a doctor if levels are uncertain. The second is bioflavonoids, plant compounds that reinforce the vein wall, reduce its permeability, and calm inflammation in vascular tissue. Good natural sources include blueberries, black currants, tart cherries, chokeberries, citrus fruits, and buckwheat. Notably, the two most widely used pharmaceutical vein strengthening medications are derived directly from bioflavonoids, and getting these compounds from whole foods tends to absorb better than from supplements alone. Compression stockings. These reduce pressure in the surface veins, decrease swelling, and ease discomfort. Genuinely useful, especially during long flights or extended periods of standing. But the moment they come off, the veins go right back under full load. Compression manages symptoms. It doesn't address any of the underlying mechanisms that created the varicose veins in the first place. It's a support tool, not a substitute for treating the cause. On surgery, laser ablation, sclerotherapy, phlebectomy. These procedures genuinely work, and the cosmetic result is real. But if the underlying cause hasn't been addressed, new veins tend to develop alongside the treated area. This shows up repeatedly in clinical experience. A successful procedure followed, 1.5 to 2 years later, by new varicosities on the same leg. The surgery itself was technically correct. It's the underlying system that wasn't corrected. Surgery has a legitimate and sometimes necessary role, but it works best as a final step rather than a first one. Going into surgery after already addressing hydration, swelling, muscle pump function, mechanical obstructions, and vein wall nutrition meaningfully improves the odds that one procedure holds for years instead of months. On blood clots, a reasonable fear, but one that's often overstated. A clot in a varicose surface vein is called thrombophlebitis. Inflammation of the vein wall with a clot inside it. It has distinct signs. The vein becomes hard and cord-like, painful to press, and the skin over it turns red and warm. Those signs call for same-day medical attention and a duplex ultrasound, which shows not just the vein's anatomy, but the actual speed and direction of blood flow inside it, letting a physician determine whether anticoagulants are needed. The key distinction: pulmonary embolism, a clot traveling to the lungs, is a complication of deep vein thrombosis, not surface vein thrombosis. Varicose veins are surface veins, anatomically separate from the deep venous system connected to the lungs, so a clot in a calf varicosity very rarely leads to a fatal embolic event. Deep vein thrombosis is the condition that genuinely warrants vigilance, particularly after surgery, prolonged immobility, or flights over 8 hours. Varicose veins do carry some elevated risk, but it's considerably lower than many people assume. Worth watching for warning signs without amplifying the fear beyond what the physiology actually supports. Age matters too. After 50, the rate at which varicose veins progress tends to accelerate for 2 reasons. In women, declining estrogen affects the elasticity of blood vessel walls directly, and in both men and women, muscle mass steadily declines with age, meaning a weaker venous pump and more blood sitting still in the veins. That progression can't be stopped entirely, but it can be slowed considerably with consistent daily habits. Putting it together, the full plan looks like this. Drink roughly 30 ml of water per kilogram of body weight daily, and add turmeric to warm meals along with ginger tea sipped steadily through the day. On the food side, cut back on sugar and MSG/processed foods. Consider a trial dairy-free period if leg swelling is persistent, and add cranberries, lingonberries, horsetail, parsley, celery, and seasonal water-rich produce. For movement, run the 3-exercise sequence sumo squats, standard squats, calf raises 3 times daily, stand and move every hour, and walk 40 minutes a day. If veins keep progressing despite all this, look into mechanical obstructions through visceral massage around the groin, intestines, and diaphragm, done consistently, since this is slow work. On the nutrient side, get vitamin D tested and corrected if low, and eat bioflavonoid-rich foods regularly. One clear warning sign to act on immediately: pain, hardness, and redness along a vein warrants a same-day doctor visit and a vascular ultrasound. Varicose veins aren't something to simply accept as permanent. They have identifiable causes, those causes are addressable, and the underlying process can often be slowed, and in earlier stages, meaningfully reversed. But only by working on the system that produced the problem, not just the visible vein itself. As with any health condition, this information is educational rather than a substitute for a conversation with a clinician who knows your individual history.